So there are different topics, and we will discuss most of them, I think. So, first of all, the first presentation is related to what happens to the lung in terms of morphology and gas exchange and respiratory mechanics when we induce anesthesia. And this is the basics for the discussion during these 3 days. This is my email, and if you want to contact me, please feel free to send me an email. And I will leave all my slides to you so you can share, of course, confidentially within the groups. I'm actually working in Genoa, which is in Ligurian Sea, and in a very big hospital, one of the largest hospitals in Italy, which is the San Martino Hospital, and I'm director of anesthesia intensive care in the same hospital. So no conflict of interest for this lecture. So this is the first slide here, and you can recognize this person is Goran Edenstierna. He's likely the father of the research in anesthesia, and especially the effects of anesthesia on the lung. And so for many years, he was interested with his team to look at the mechanism, why anesthesia induces changes in the lung morphology and gas exchange. And this is one of the first experiments they did in animals at the CT scan. These are ponies anesthetized. And this is the CT scan of a pony, of course sedated. And you see here the stomach, you see here the lung, and the very few amount of atelectasis when the animal is sedated. But when they, are you sure it's working? Here it works, but not by this. I don't know. So when the animal was paralyzed, you see there was a major reduction in the lung volume, the black area, and a major increase in the white area. So the atelectasis is in the independent part of the lung of the pony, also because the thorax of the pony is very high. And this occurs also in humans, and these are CT scans for humans. You can see, no, it's not working. And you see that, I hope that at least here. This is a CT scan of a awake patient. And during anesthesia, you see the cranial shift of the diaphragm with a minor atelectasis in the most dependent part of the lung. And when you induce paralysis, you have no major changes. So the first concept here is that deep sedation and relaxation of the respiratory muscles is one of the main causes of atelectasis formation. And most importantly here, the atelectasis are maintained up to 48 to 72 hours. So message here, anesthesia induces a reduction in lung volume, atelectasis formation, and this atelectasis formation is maintained for 48 hours or 72 hours after surgery. How many atelectasis, however, do we have? This is extremely important when we discuss recruitment and protective ventilation later. This is the distribution of the percentage of atelectasis along the percentage of lung tissue. You see that most of the patients present maximum 3 to 4% atelectasis per the percentage of the lung tissue. And other patients present a very high amount of atelectasis. So the concept again here, and you have to take in account when we discuss protective ventilation and recruitment during anesthesia and possible effect on outcome, is that most of the patients, they do not develop major atelectasis during surgery, and we are talking about a minority of the patients. So if you think to perform open lung strategy or recruitment in all patients without any clear strategy, we believe that this is not good. We have to identify those patients likely that are developing a higher amount of atelectasis. Can you imagine if you apply a very aggressive maneuver in patients like that with a very minor amount of atelectasis? You just overinflate the lung. We will discuss that in one of the lectures. And if you believe that you can look at atelectasis at chest X-ray, this is not true. You see here an example. There's a major atelectasis in the dependent part of the lung, and you don't see almost nothing at the chest X-ray. Why that? Because they're always in the dependent part of the lung. The chest X-ray is from the front to the back. So very often, it's almost impossible to look at these atelectasis at the chest X-ray. And this is make a major issue in terms of clinical diagnosis, especially in the postoperative period. You look at the normal or relatively normal chest X-ray, you say there are no atelectasis, really you have these atelectasis in the most dependent part of the lung. There are some patients in which you have an increase in the amount of atelectasis. You see here these are normal subjects awake around non-aerated tissue, around 0.5%. When you induce anesthesia, you see almost around 3%, as I showed you before, some patients much more. If you are obese patients, you have no major atelectasis, of course, during spontaneous breathing due to the tone of the respiratory muscles. When you induce anesthesia, you see a major amount of atelectasis, around 11%. And some patients may reach up to 20% of the lung tissue. So obese patients are characterized by massive atelectasis during surgery. And why that? Because you have an increase in the intra-abdominal pressure. In normal subjects, you have around 7 to 8 centimeters of water. In obese patients, you have 17 to 18 centimeters of water. I'm talking about morbidly obese patients. And this induces an increase in the pleural pressure, and this promotes the squeezing of the alveoli and atelectasis. So higher is the level of obesity, higher is abdominal pressure, higher is the pressure in the pleura, which squeezes the atelectasis mainly in the most dependent part of the lung. And you see here the body mass and the amount of atelectasis. It's not a really very, very good relationship as you see here. There is a correlation, but you see at 30, 35, they did not look at patients with higher amount. I will show in another lecture there. But you see you can have a very wide spread of atelectasis. Anyway, with higher than 30, you are almost sure that you have an amount of atelectasis which is absolutely higher than in normal subjects, okay? And what about perfusion in the atelectasis area? This is the CT scan with atelectasis here. This is the amount of perfusion in the dependent part of the lung. And you see this area as relatively well perfused. So there is not much hypoxic vasoconstriction or reduction of the flow due to the reduction in the capillary diameter. So these areas are relatively perfused, and this is the reason why atelectasis are associated with an increased shunt. There is one group of patients, there are very few studies on that, who do not develop atelectasis. These are the COPD patients. You see here COPD in awake situation. This is, you see here, the VIQ match between flow and ventilation. This is a major VIQ mismatch in COPD patients, not much shunt. During anesthesia, you see shunt does not increase too much, no major atelectasis, but a major VIQ mismatch between ventilation and perfusion. So the COPD patients do not develop too much atelectasis. Really, this is a very old study. Not many other studies investigated this issue. It's very likely that in this condition, this patient had some autopip, which could have masked some atelectasis. But anyway, the concept here that the COPD patients do not develop major atelectasis, differently from normal or obese patients. but they develop VIQ mismatch. They do not develop shunt, okay? Can you imagine in these patients, you have not to be aggressively recruiting these patients. You have not to be aggressively use PEEP in these patients. What about prone position, which is extremely a very particular position? We did 2 studies in normal subjects and in obese patients. This is the FRC, this is the PO2, and you see that in prone position, we always observe an increase in the FRC in normal or obese patients between supine and prone position, as well as an association with PO2 and respiratory mechanics. So prone position during anesthesia is associated with an improvement in lung function. Of course, you can have other problems, but not related to the lung function. So to summarize about atelectasis in anesthesia, most patients develop atelectasis, but very few, they have a higher percentage of atelectasis on the lung tissue. They are not seen at the chest X-ray, are more in obese patients and less in COPD patients. Which is the clinical relevance? We will discuss in a lecture, I don't know if today or tomorrow, about the role of protective ventilation and outcome. We have intraoperative atelectasis, which can induce postoperative atelectasis, as I told you, and these might promote acute respiratory failure. So the idea is that if we reduce or minimize atelectasis during surgery, we have this less atelectasis after surgery, and this might be associated with less complication. We don't discuss now this, but we will discuss that in this issue in the next lectures. And you see here one of the first studies looking at the awake at 2 days postoperatively, second day postoperatively, in this case not major atelectasis, and this is the amount, however, atelectasis increases at 2 hours, and they are maintained at 1 and 2nd day postoperatively, and they disappear at the 4th day. And this is associated with a reduction in PO2 and a reduction in functional vital capacity or pulmonary function test. So, of course, that you see here, there is a major widespread of atelectasis postoperatively. I will show you also some very recent data at magnetic resonance we got about this. And these are data related to postoperative complication and pulmonary function. Here, we see here, on average in our studies, we found around 8 to 10% of the patients developing pulmonary complication after surgery. So it's not a minor problem. And you see here in green, patients undergoing abdominal surgery or thoracic surgery without respiratory failure or lung injury after surgery. Mortality at 30 days is around 1.5. And what we found here in red, the patients undergoing abdominal surgery who developed respiratory failure, so lung injury, you see here 25% mortality at 30 days. So if you develop lung injury, very high mortality. And you see here thoracic patients who develop lung injury after surgery, mortality at 30 days around 30%. So this is a major issue. Postoperative pulmonary complications are frequent, around 10%. And if you develop pulmonary complication after surgery, mortality is very high. So we have to understand if mechanical ventilation or other therapeutic managements may be helpful in this. How can we detect patients who are developing atelectasis? You see here the PO2-FiO2 ratio and the inspiratory oxygen fraction, and this is the shunt fraction. So you see that if patients are ventilated in air, you can very nicely discriminate those patients who have higher amount of shunt or lower amount of shunt. Just to have a look here, if you have a high amount of shunt, you see you have a PO2-FiO2 ratio around 150, so means that you have a PO2 around 50. So means that saturation is around 88 in air. So we can say that if you have around here a 20% of shunt in green here, and you are ventilating here at approximately in air, you have divided 300 divided 5, so you have around 60. So means that if the patient is in air, not oxygen, because with oxygen you mask everything, the VIQ and shunt, but patient is in air, and you have a saturation around 91, 92, you are developing a shunt around 20%. If in air you have a saturation below 95, means that you have a shunt around 10, 12%, okay? So there was a nice study from our colleagues in Spain. They look at the air test. So you put the patient in air, not oxygen, for a short period of time, and if saturation is below 96, the probability that these patients are developing some atelectasis in the lung is very high, with a sensitivity of 85, 90%. And according to these, they found that atelectasis were present is around in 36% of the patient postoperatively. So this is our data in a large study that we perform magnetic resonance after surgery in patients undergoing open abdominal surgery. And you see here the postoperative atelectasis measured quantitatively at the magnetic resonance. It was not an easy study. It was in more than 70 patients. And this is the postoperative saturation in air. And you see here that if the saturation in air again is higher than 95, you are likely not to have any atelectasis in most of the patients. If the saturation in air is less than 95, 2/3 of the patients, they have a higher amount of atelectasis, while 1/3 they have not. So if you measure oxygen saturation in air intraoperatively or postoperatively, you can easily exclude those patients that are not developing atelectasis. If it is less than 95 in air, you are very likely to develop atelectasis. You have 1/3 of the patients that likely alteration in oxygenation are not due to atelectasis, but for example, some lower VIQ due to the peripheral secretion or other reasons. So this is something very important. Now we know that we can detect at the bedside the risk to develop atelectasis just measuring oxygen saturation in air. And this, I think, should become more and more common during anesthesia. We can think to reduce FiO2 in air. You look at the saturation. If saturation is higher than 95, you have not to apply very high PEEP, you have not to apply recruitment maneuver, nothing. If it's lower than 95 in air, probably the patient is developing atelectasis. It's possible that this patient would benefit from a little bit higher level of PEEP or recruitment. The other method, of course, is echo. We have one lecture on echo. I don't focus here, but discuss that into detail. But echo is very important, and we use echo now in intensive care for most of procedures or diagnostics, cardiac, fluid, and lung. But what I want to say is that we should use echo, especially for the lung, more and more in the perioperative period. We don't, at least in Italy, we are not so used to do that in the ward. Airway closure, this is extremely important. It's not only a problem of atelectasis, but also a problem of airway closure. This is the lung volume, this is the age, this is the closing volume. This is a normal subject upright, and you see that more or less the closing volume approaches the lung volume at end expiration when we are older than 70. When you are supine, around 50, you see the closing volume is higher than the lung volume. When you induce anesthesia, the crossing, because the closing volume and the lung volume is a lower lung volume and occurs early. And these are the data of the FRC here, in spontaneous breathing or during anesthesia with different type of ventilation. And this is the closing volume. You see that closing volume is higher than the FRC. And in obese patients, there's an even much higher difference between closing volume and FRC. What does it mean? That we have three areas, well ventilated, atelectatic, but also this area of closing volume. These areas are the areas in which the peripheral respiratory bronchioli collapse. These are areas of VQ mismatch, not of shunt. That's why we have to perform the test that I showed you before in air. Because if you do that in oxygen, you mask the effect because you don't take into account the area of low VQ. And these areas are extremely important because they may induce lung damage due to the continuously opening and closing of the peripheral areas. So when the closing volume is lower than the FRC, of course, this may occur. What about gas exchange? As we discussed before, this is the correlation between atelectasis and shunt, which is very good correlation, as I showed you before. This is the correlation between airway closure and the low VQ areas. You see that the airway closure is, when airway closing volume is higher than the lung volume, you see that you have an increase in the low VQ areas. So overall, the PO2 is determined during anesthesia by the amount of atelectasis, but also the amount of airway closure. And I show you that airway closure may be associated with lung injury. It's not only a question of atelectasis. It's a question also of collapse of the peripheral areas. How to reduce atelectasis? First of all, this is, of course, is not practical, but just to know, ketamine is the only drug which maintain the muscle tone and preserve the muscle tone, and with ketamine you do not have any atelectasis. Of course, it's not for all surgery, even if now we did no opioids. Perhaps we discussed when we discussed obesity, I don't know here what you do, but now we're more and more the non-opioid anesthesia, which is something related to this. And of course, phrenic nerve stimulation, which is just for proof of concept. This is an example with ketamine, with spontaneous breathing, or with paralysis. You see that if you paralyze the respiratory muscles, you have atelectasis here and the cranial shift of the diaphragm. If you have spontaneous breathing with ketamine, you have no atelectasis. Very clear. On the other side, this is with the phrenic stimulation. On the right, and on the right and on the left, the stimulation was here, on the phrenic stimulation on the right. You see a reduction in the amount of atelectasis due to the phrenic stimulation. And you see here on the right, the control with PEEP, after PEEP, and after PEEP with phrenic stimulation. And the left lung, no changes due to the absence of phrenic stimulation. So this means that the tone of the respiratory muscles is important. Avoid high FiO2. This is another important issue on how to prevent atelectasis. during anesthesia and induction and during anesthesia. The risk of hypoxemia is very low. Why that? Because the respiratory quotient is the ratio between VCO2 and VO2, and on average is 0.8. So this means that the absorption of oxygen is higher than the production of CO2. Why the alveoli are stable in normal condition? Because we have N2, which is a stabilizer of the alveoli. So what happens if we increase the FiO2, we wash out the N2, so at the end we have a higher absorption of gas than the amount of gas reaching the alveoli, and so you have a collapse. And this is what happens in red. This is the minute time to collapse, and this is the inspired ventilation perfusion ratio. So here is very low, this is higher. And you see here that if you use 100% oxygen, you have an increased washout of N2. You see that with higher or lower ventilation perfusion alveoli, you see that you very short time before you collapse, okay? If you have a lower FiO2, of course, if the ventilation perfusion, which is the VAQ, is high, you have no problem at all. If you have a relatively low, it takes hours before you collapse. So higher is the amount of FiO2, and lower is the VAQ, okay? So higher amount of atelectasis you have, you promote even more atelectasis. And this is an example from a famous study from Roten many years ago. This is awake. This is induction at 0.3. This is induction at 0.3. This is induction at 1%. You see that oxygen at induction plays a major role to develop atelectasis. And however, we have to remind that oxygen inspiratory fraction below 80% does not promote too much atelectasis. So the problem is when we induce atelectasis with FiO2 higher than 80%. So just enough to induce anesthesia at 80%. In risk patients, of course, obese patients, you can reach 100% for safety. And of course, the time and the reserve for desaturation, you see if you induce at 100%, you have a desaturation time of around 200 seconds. So it's around 3 minutes, but if you induce at 80%, it's around 5 to 6 minutes. So, and longer if you induce at 60%. So just to tell you that you have not to fear too much to use lower FiO2 at induction, at least in patients which you do not expect major difficulty at intubation. And this is what happens during anesthesia from baseline to 17 minutes in the high FiO2 and low FiO2, but high FiO2 here is 100%. So very high FiO2. Recruitment, we don't discuss that because too much, because we have a lecture on recruitment, but just showing that you need high pressures, around 30 to 40 centimeter of water. This is the atelectasis, this is the air pressure, to recruit the lung. Of course, if you have not much atelectasis, the question is, do we need the recruitment or not? But this will be matter of further discussion. Remember that when you perform a recruitment maneuver, then it takes a long time before you have a further increase in atelectasis, especially if you ventilate with high FiO2. So usually we apply recruitment and TEEP, but very few studies investigated the role of recruitment per se with low PEEP level after recruitment. But we will discuss that into detail. PEEP we don't discuss now. I would like now to have some words about dead space and mechanics, just 10 minutes. Usually, the CO2 is used for monitoring. You recognize here a normal capnogram in the expiratory phase. In COPD patients with airway closure, you see a different pattern. And if you have not give time enough to expire, you underestimate the entitled CO2. Okay? Because you need time in order to reach the equilibrium between the alveolar CO2 and the CO2 in the blood. When you have CO2 rebreathing, you have a progressive increase in the entitled CO2, but also at inspiration. You see here at inspiration. When you have missed esophageal intubation, you know this is one of the best methods to look at the missed intubation. Ineffective muscular blockade, you can have some swings, especially here during the expiration. You try to inspirate and the expiration. And when hypoventilation, we have a progressive increase in entitled, but at the end expiration, but not at the inspiration, differently from the CO2 rebreathing. So CO2 monitoring is very important. But what we don't use very often in operating room is the volumetric capnography. And I suggest you with this very recent review published, because it's very important to know more and more the information about the anatomical dead space and the alveolar dead space, which the sum of them represent the physiological dead space, and so measure the effective ventilation. You know that there are two methods. This is the expired CO2, this is the tidal volume. Expired CO2 is the tidal volume. This is the curve of expiration. Usually, you have information, automatic information, of the alveolar dead space, anatomical dead space, from the middle of the initial phase of expiration here. And then with the Bohr method, you assume that the alveolar, that the PSO2 is given in the middle of this second phase of expiration. With the Enghoff method, you have to measure the PSO2, and sometimes this is not exactly the same of the alveolar PCO2. So the question is that the Bohr method usually does not take in account the possible changes in the physiologic dead space due to the shunt, while the Enghoff measuring the PaCO2 includes also the possible effects of shunt on the calculation of the dead space. So overall, if you have the expired CO2 and the volume, you can get information about the anatomical dead space, because you can measure automatically on the middle line of the expiratory CO2 here. You have information about the physiological dead space. In this case, usually is measured by the Bohr method. So looking at the estimation of CO2 from the expiratory curve of the CO2. You have information about the alveolar ventilation dead space, alveolar dead space, and the effective alveolar ventilation. So what I mean is that with the volumetric capnography that I think we should use more and more in the operating room, we can get information about the real fraction of tidal volume which is really ventilating the lung, okay? This is extremely important in view of protecting mechanical ventilation. So if you use less and less tidal volume, it's becoming more and more important to understand how much is the effective alveolar ventilation, and especially during laparoscopy, when you are giving some additional CO2, and it's not very clear sometimes if the increase in CO2 is due to the reduction of the effective tidal volume ventilation or the amount of CO2 that you are giving by laparoscopy. And the second point is that if you reduce the tidal volume due to the protective ventilation, it's becoming more and more important to know how much of this tidal volume is really ventilating the lung. So this is just a glimpse and just few notice about the role of volumetric capnography that I think should be more and more included in the monitoring system, also in anesthesia. We are using this more and more in intensive care. Now in all our machine, we have equipped with volumetric capnography. I think we should take care more about this also in anesthesia, especially in more severe patients. This is just an example. You see here, you have, for example, you have tidal volume here, 390, which is the sum of, you see, physiological dead space and the effective tidal volume. And you see that the physiological dead space is done by anatomical dead space and the alveolar dead space, you see? In this way, you can separate all the different components of the tidal volume. What is important is the effective alveolar tidal volume. So if we reduce the overall tidal volume, which is the sum of physiological and alveolar effective, you can understand that you can have a reduction, of course, in the anatomical dead space, and also you can have an effect on an effective tidal volume. Just few notice about mechanics. So this is a typical curve with the flow, with the volume, and with the airways. You see here that what is important is that at the end of inspiration, you have to occlude the airways, and this is an issue. In some ventilators you can, in others you cannot. Or you have to increase the inspiratory time in order to reach the plateau pressure of the respiratory system. And also the occlusion at end expiration, you see here that from the level of PEEP you have an increase in expiration at occlusion. This is due to the presence of auto-PEEP. That you can suspect here, for example, because you see that the flow at end expiration is not going to zero. So the monitoring of the flow and pressure with time is very important. To get information about the plateau pressure, which is extremely important, to have an information of PEEP high, which can be predicted by the presence of positive flow at end expiration. The other issue to remember that we are ventilating in volume control. This is a mistake here. You see that this is the peak, which if you have an increase in the peak pressure, this can be due to two phenomena. The first phenomena is the increase in the airway resistance. So if you occlude the airways at end inspiration, you have a plateau pressure in blue, and you have an increase in the difference between peak pressure and plateau pressure. So if you have an increase in peak pressure in volume control, you have always to occlude the airways at end inspiration when possible. And if you have an increase in the difference between peak inspiratory pressure and plateau pressure, this means that you have an increase in the airway resistance, okay? If you have an increase in the plateau pressure, you see in red, so the difference between peak and plateau remains the same. This is likely to have atelectasis of edema or some parenchymal problems. So airway occlusion are very important in volume control to detect problems in the lung. If you are in pressure control ventilation, when you have a reduction in the compliance of the respiratory system, you see you have a reduction in the inspiratory flow and a reduction in the volume. And of course, the CO2 increases. It's a little bit more difficult here, of course, to detect if this is due to the resistance or the elastic component. Another parameter that we will discuss and from clinical point of view, but this is theoretical, is the driving pressure. What is the driving pressure? The driving pressure is the difference between the plateau pressure and the pressure at end expiration or occlusion, okay? We never look at that in anesthesia. I will show you in another big survey that we did in another lecture. Why driving pressure is very important, and we don't measure. More than 70% of anesthesiologists, they don't measure driving pressure during anesthesia. It's important because the driving pressure is the difference between plateau pressure of the respiratory system and PEEP, okay, or auto PEEP. So it's the ratio between tidal volume and the compliance of the respiratory system, okay? In other terms, is the tidal volume divided the end expiratory lung volume. If you assume that the compliance of the respiratory system is associated with the aeration in the lung. Are you following me? More lung you have, imagine that you have a lung like that, with more aeration, okay? Full of air. And you are ventilating with 500 milliliters, okay? And imagine that you have a driving pressure of 7 centimeters of water. This is a representative of the strain, because this is the pressure to deliver a tidal volume within a certain amount of gas, okay, of aeration. Now imagine that you have a lung like this. This is RDS, but just to give you an example. You have much less air here. You give the same tidal volume, but driving pressure is 21. What does it mean? That the tidal volume that you are delivering is much higher than needed in order to avoid lung injury as compared to the amount of tidal volume that you deliver in this condition, because you have less air in the lung. So in other terms, driving pressure is a very, very easy method at the bedside to know if the tidal volume that you are delivering is in excess related to the aeration of the lung, okay? This makes a major importance in patients in which you are doing operation and you have also some problems in the lung. And I will show you that now we have data showing that if driving pressure is higher than 13 during surgery, independent of a lot of laparoscopy, the risk to develop PPC that I show you are very much associated with worse outcome is increased. We will discuss later. But just to tell you what is driving pressure. And another thing that we have to learn more is the ratio between the pressure, this is in constant volume, not pressure control, but in volume control, and time. When you see here a concavity towards the x-axis, you see here an increase in pressure during constant flow. This means that you are stretching the lung or the respiratory system. If you have a convexity like this, means that you are going from atelectasis to opening, okay? You are opening and close. When it's linear, you are ventilating the lung in the open condition. So the other suggestion, look always at the monitoring of pressure on time during constant flow and try to avoid especially this condition in which you have an increase in pressure at the end of inspiration. This means that we have an overstretching of the lung at inspiration. This means that we are ventilating with too high tidal volume or too high PEEP, okay? And finally, the flow curves. This is normal, this is airway collapse, this is airway narrowing. And this is the inspiration and this is the expiration, the flow and volume curve. This is another flow pattern that we are not very used to look at, not only in anesthesia but also intensive care. In the normal condition, you see that more or less we have a constant expiration during volume. When you have airway collapse, what does it mean, airway collapse? Typically of emphysema, you have a collapse of the airways during the end of expiration. And you see that you have a peak flow, which usually is lower than normal, and then you have a convexity towards the volume axis, and then you have flow, no zero flow at end expiration, okay? So this is, you are likely to have auto PEEP here, because you have no zero flow, and you have this kind of curve in expiration in flow volume curve. These patients have airway collapse, so this patient likely benefit a small amount of PEEP, even during the extubation phase, okay? Then you have another patient with airway narrowing. These are patients with asthma. And you see the flow is not zero at end expiration, so exactly like here, and auto PEEP is likely the same, okay? But the flow here is the flow volume curve is a completely different shape from here, you see? More linear with flow at end expiration. These patients, they have no airway collapse, but they're just airway narrowing. If you add the PEEP, you will further increase the pressure. So never add PEEP in this condition. In this condition, you have to give bronchodilators. So you see here how many information you can get from airways, occlusion, and flow volume curves. And probably we have to be used more and more. We can skip there. I want just to finish. This is esophageal, but it's too much. So I show you that impaired or inadequate oxygenation in the perioperative period is a clinical problem and can result in morbidity and possibly mortality. And PPC are the most important. Atelectasis is a major cause of impaired gas exchange in the perioperative period. Airway closure can contribute to VILI, and that's why it's very important to perform the air test, because the air test includes the atelectasis and the low VQ area. If you use higher FiO2, even at 50%, you don't get any good information on that. I think that saturation in air should become a standard in the preoperative visit, during anesthesia, air test, and in postoperative period. It's the best method at the bedside to predict those patients who are developing low VQ and atelectasis. And then we can discuss the strategy. For individualized treatment, this is extremely important. If we don't have individualized treatment, it's likely not to get good results. Obese patients tend to have more atelectasis than lean ones, and patients with COPD have a marked VQ mismatch, but in general, no atelectasis. Of course, obese patients, if you reduce the FiO2, their tests give you possible presence of atelectasis, even if this is due to low VQ. So COPD are always very tricky. How to avoid atelectasis? We should avoid high fraction of oxygen in inspired gas, or the use of PEEP may help eventually to prevent atelectasis. We will discuss in another lecture, but here I want to focus on the high fraction of oxygen. Don't use too much oxygen. We will discuss the WHO recommendation. I'm absolutely against what is written, and I will discuss you in another lecture when we discuss the extubation. But my feeling, don't use IFR2, just FR2 you need at intubation, during surgery, and postoperatively. Recursive maneuver combined with PEEP can be used to reduce the amount of atelectasis, but only in patients who need. And we will have a lecture on that. I show you driving tidal volume. We did not discuss too much now, but I show you that driving pressure is a new parameter that we have to take in account. Volumetric dead space, transport we don't discuss too much, and respiratory mechanics, as I show you, are extremely important to have more information in our patients. If you need more information about transpulmonary, we can discuss that, but I don't think that actually is something that can be applied easily at the bedside. But it's something more that can be considered, okay? So this was the first part of the mechanics.